Yeah, you're live. You can start.
Good afternoon, everyone. This is Ankita Mishra here, and on the behalf of ForOptom eLearning team, I would like to welcome all of you, whoever is watching on today's session. Before it starts, I would request all of you, if you have any queries, to put in the comment section below. We have separate queries to put it in the comment section below. And at the end of the presentation, we will answer all your queries. So without any further delay, today we have Mr. Aditya Tripathi, who is postgraduate from Institute of Paramedical Science and Management from Tamil Nadu. He has done his Bachelor in Optometry from uh, Patil Medical University, Pune, and long-term fellowship in Clinical Optometry from LVPEI, Hyderabad. He has gained clinical skills at RIO Sitapur Eye Hospital, IRAS Medical University, LVPEI, Dr. Patil Medical College, I7 Lasik, and Eye Care Center and Eye Care Center. He had also worked for retail sector with corporate like Titan Eye Plus North region. He has dedicated himself into academic for last 8 years with he practiced in subjects like physical optics, geometric optics, optometric optics, and contact lens. He is currently working as an academic head in optometry department in University of Medical Science, Saifai UP. So today he will be taking session on dispensing for presbyopia. So today's session will be very insightful. So welcome, Mr. Aditya Tripathi, sir.
Good afternoon, everyone.
Good afternoon, sir.
So, as today's the topic is dispensing for presbyopes. So, first, I want to discuss that which topic we are going to discuss in this talk. So, actually, the topic denoting we are going to discuss about the presbyopia. So, first, I'll take the definition of the presbyopia, options which is available. Today we are talking about the lenses. So lenses option which is available, facial measurements, frame adjustment, and suitable frames, etc. So first definition of presbyopia. Actually, the presbyopes means the old and opia means vision. So it's something denoting the aged eye, refer to the slow, normal, naturally occurring age-related irreversible reduction in maximum accommodative amplitude. Means recession of the near point, sufficient to cause symptoms of blur vision, ocular discomfort, or asthenopic symptoms related with working distance. So onset is around the 40 to 45 nowadays. Whoever working on laptops, etc., they are getting problem earlier. Inertia of the focus when switching the gaze is different distances. Vision at the customary near working distance is the blurred or can be sustained only with excessive accommodation effort and ocular discomfort. Reading material must be held farther away to be seen more clearly. Drowsiness after short period of reading. Another features are asthenopia related to attempt as excessive accommodative effort, transient diplopia, symptoms intensified under the inadequate light, amplified by poor contrast, and exaggerated at the end of the day usually. Decreases amplitude of accommodation. So option for correction of the presbyopia is non-surgical and surgical. So in non-surgical, ophthalmic lenses, single vision, bifocal, multifocals, and progressive. And contact lenses means multifocal contact lenses or monovision, etc. Surgical refractive surgeries like the presbyopic LASIK surgery or radial surgeries, etc. So single vision lenses correction only one distance at a time. Inconvenient because it's only for one distance. Blur for distance when we are the patient is using for the near. Carry two separate glasses if they have the distance and near problem both. Oldest method Next is bifocal. In bifocals, distinct junction between zones, cosmetically unappealable, sometimes confusion in focus, intermediate blur, older method, image jump, and segmented portion. Similarly, here the trifocal and tetrafocals. They have also the similar like the bifocals problem, distinct junction between zones, cosmetically unappealable, older method, image jump, and segmented. So what are the bifocals? Actually, the lenses have both correction for the distance or near means have two focal points and two powers in a lens. They are known as bifocals. So widely used bifocals are the Franklin executive bifocal, fused cryptoc bifocal, cemented bifocal, solid bifocal, and flat top bifocals. These are the types on the basis of manufacturing methods. So first, the executive or Franklin bifocal. mm, this type of the bifocal are the first because the first bifocals invented by the Franklin. So they have the separate two radii and two power. At half portion have different power and lower half portion have different power. And it's have heavy but have wider field of view and less aberrations. Second is fuse cryptoc bifocal. They fuse by the major and minor segment portion, and by that they manufacture segmented of a flint glass was fused. Cover glass was not needed. After fusing, the surfacing is done for front surface. Advantages: segmented edges do not collect dust and dirt. Segment did not fall out and it was invisible almost. Can be produced in large quantities on commercial scale. Disadvantages: transverse chromatic aberration and image jump. Third is fuse flat top bifocal. It's optically better because in this image jump is less difficult to manufacture usually in glass. D-shaped segment is molded on the front surface in plastic and fused in glass. Different refractive index for the both major and minor lens. Major portion, that is the complete lens, and minor is segment portion. Next is Ultex or solid bifocal. They have the two curvatures, a large blank surface and ground in the form of saucer, and different curvature. Upper portion is for distance and lower is for near. So here the some terminology used in the bifocals: segment height, segment size, segment depth, and segment drop. These are terminology used for the segments. So it's if we are measuring the height from the bottom to the segment border, that is known as segment height. Segment size is the size of that segment. Segment depth is the upper portion of that segment to the lower portion, and segment drop, it's drop distance from the major reference point to the upper portion of the segment. So fitting of bifocal, the vertically lens is fitted usually 3 to 6 below pupillary center. Horizontal is depend on the segment inset. So actually the it's vary because the it's depend on the need of the customer. If customer or patient have a need of more near vision, we have to put that segment size little upper, means nearby the pupillary border. If the uh, patient have less near vision, then we can keep lower than lower lid also. So it's vary. Near things are needed for prescribing or fitting of that bifocal lenses. Near PD, monocular near PD, it's either can measure or by calculate by the distance PD. Inset is just the in this you can see like that the difference of the distance, major reference point, and the near that near PD is known as the inset. Inset is used only for the segment. So how we can calculate? We can calculate by distance PD minus near PD divided by 2. Next is the effective dia. Effective dia, whenever we are prescribing the lenses bifocal or progressive lenses, that time we need to give the measurement for total diameter because it's vary from 50 to 60 or 65 70 dia, means diameter of the complete. So if we select the large frame and just order the lens and we doesn't give the information about the diameter, then might be the lens whatever we are getting that will have the lesser diameter and we cannot fit in that frame. So for that we have to give the total diameter, approximate total diameter. So how we can calculate? We can calculate from the distance, means maximum distance from frame center to the just multiply with 2 and add the 2 if the frame is full frame. Next the problems are next are the other problems with bifocals: image jump, differential displacement of reading levels, and total displacement and chromatic aberrations. So image jump, image when I transfer from the distance portion to the near portion for a bifocal lens, sudden change to the prismatic effect, and because of that because of entering that prismatic effect, sudden introduction of the base down prism by the segment as I cross the dividing line. So for calculating the jump, segment radius in centimeter multiplied by addition. So independent of that image jump is independent of the power of main lenses and the position of the distance from optical center. So so the problem with the bifocal lenses, the frames are uncomfortable. The glass would not stay on the position. The lens are too thick. The glasses feel too heavy. Vision blur at a distance and near cannot read with new bifocal. Eye tired with the new glasses. Better without them. Have the headache when with the new glasses. Hello.
Hello.
Next is the progressive lenses. So progressive lenses are lens designed for the presbyopes with power gradually increasing, varying from the distance zone through a corridor to the near zone. Means these are the multifocals, a type of multifocals. So uh, history of the progressive lenses is first progressive lenses patented in 1907. Owen F's, that was the biconvex, no astigmatic correction, hyperopic correction, only in 1909, Henry Goland patented base back surface conical section that was the elephant trunk shape. Modern progressive edition lens in 1915 developed by Bernard Maintenance. First commercial progressive edition lens was manufactured by the Verilex one in France in 1959 by the ASIL, which converted later on in Asilor company. So need for the progressive edition lenses, aging public, visual demands, cosmetic, better quality of optics. So myths behind the progressive edition lenses, difficulty to prescribe and fit, not adaptation, non-adaptation. Progressive edition lenses are expensive. Only cosmetic, lenses only for the cosmetic appearance. So patient expectation with the progressive edition lenses, good vision for all distances, quick to get adopted, it is easy to use, value for money, technology and trust. So progressive edition lenses, blanks look like this, and they have some temporarily or few permanent marks. So progressive edition lenses are and have uninterrupted vision for all distances, no visual junction, cosmetically appearable, no aging appearance because of unappearable of that dividing line, convenient, no image jump, no differential displacement, naturally head movement. Basic characteristics of the progressive edition lenses: distance area, stable distance power zone, near area, stable near power zone, length of reading zone between the 14 to 16 mm, periphery astigmatism that was unwanted, intermediate zone or corridor or channel, those have the different power or power in form of the progressing. Length of the progressive corridor, distance between MRP and stable near power 11 to 14 mm. Manufacturer MRP to edge of the near zone. Corridor width smaller at MRP and become larger toward the edge. Corridor is short, progression greater if ad is high. So higher the peripheral astigmatism, lower the corridor width. Unwanted astigmatism and distortion proportionally increases with distance from channel. Corridor length is the important factor for progressive addition design. So how they are going to increase the power from distance to near. So if progression zone is near, then the change in the power depend upon the near addition power and the length of progression zone. So both things are important, means addition power as well as the length of the progression zones. For each of the progression zone, the increase in the power, like according to the formula, when we put the power, means if the power change is addition power is 1.5 and the progression zone length is 10 mm, then the change in every 1 mm, it will be must be changing is 0.15 diopter, and it must be changing at the rate of 0.075 diopter in every half mm. So this is a curve which indicates the vertical power progression. So we can divide, divide the types of the progressive addition lenses in different type on the basis of their designs. So first was the hard design lenses. So hard design was the primary design. Previously successful hard lens were and people who do a lot of reading work, means in that the corridor have very less width. Soft design lenses are the most wearers nowadays. Usually we are using in all lenses the soft design only. And younger presbyopes, first or second presbyope prescription, soft design we are giving. Active outdoor types, because in this the distance near and intermediate zone width is more. Professional drivers, etc. Spherical and aspherical type of the designs. Spherical, it have a distance area with a relatively less astigmatism. Distance area same as single vision. Harder design because it's have the near and distance portion more, and wider distance and reading area. Steep transition, more peripheral abrasions, less eye movement vertical, because the distance and near portion are more. Aspheric design, it use a uh, larger area for distribution of astigmatism. Here in diagram also, the first diagram is spherical and second one is aspherical design. Distance peripheral area is aspheric, softer relatively, smaller area for distance and near corridor width, length increased. So corridor area is more, less peripheral abrasion because abrasion distributed in larger area. Eye movement more vertically because it's have the different zones and the intermediate zone are larger. Next is symmetric, dissymmetric and asymmetric design. Symmetric refers to inferonasal and inforotemporal sector of blank. They are the similar, means both sides are almost similar. Symmetric blank can be rotated by 10 degree to create inset. So similarly, like we did in bifocal, here also we need some inset. So for that, in symmetric design, uh, a single lens we can fit in right as well as in left lens, left eye. Just we have to rotate 10 degree, 10 or 15 degree, whatever require. Usually the 10 degree. One single front surface design, it's economical. Both eyes subjected to different kind of astigmatism, affect the binocular vision, stereopic depth perception. Dissymmetric unwanted astigmatism concentrated in inferonasal part of the blank. Inferonasal part as of inset, relatively less peripheral abrasions, small eye size frames. Asymmetric, the individual lenses with inset, means it's already comes along with inset, means for right eye and left eye separately it's come along with inserts. Rotation not required because when you rotate it will not fit in another eye, means it's come with the denotion with the eye also, because we cannot rotate and make it make to fit in another eye. Attempt to maintain optical similar point before each eye. Temporal prismatic power more significant because nasally we use more while looking at the intermediate and near. So binocular vision enhanced. Next is monovision and multivision. Sorry, mono design or multi design. So mono design, most progressive lenses are mono design. That is the basic one. Some front surface design are all add powers. Amount of astigmatism is proportional to the add power. As add increases, astigmatism increases. Ratio remain same for add and astigmatism. Multi-design, series of the lens design to control abrasions. Uh, in infinity lens uses more than 12 different design. Lower edition abrasions are limited to lower half of the lens. Spherical distance, less abrasions, astigmatism increases with higher addition. Different design used for each add power to distribute the abrasions. So multi designs softness remains throughout the add power ranges. Adopter has 5 different design for 12 add powers. Lower addition adds the corridor length shorter. As the add increases, the corridor length increases and reading area decreases. So disadvantage, so many advantages we know about the progressive. Have the no demarcation line, how comfortable vision, how we can see with that lenses with all distances. So some disadvantages like the peripheral abrasions, some adaptation problem because it will take the time duration to adopt. Whenever first time wearers start to wear that progressive lenses, more critical fitting is critical, needs exact fitting. We cannot fit, means whatever we are getting reading, according to that only we will fit exactly in that frame. More expensive in compared to the single vision as well as the bifocal lenses. Dispensing progressive lenses is an art. It's require adequate training and skill to fit. Proper frame selection and good fitting require. Educate about the lens design and proper use of the lens portion for the different portion for the different distances. It involves communication and counseling skill and convincing power, and as well as a science. It's require the symptomatic approach, understanding the limitations, understanding of potential problem, in-depth study of design. So whom we to fit that progressive lenses, we can fit in all presbyopes, but contraindication in few cases like the direction of gaze. When a person have want to see or want to read on by the upper portion, they cannot read because this upper portion used for the distance. Field of view, few person wants the more area to see for reading or viewing at a time. So for that, they, if they have selected primary level of the progressive lenses, then they can get the problem. Head movement or mobility, like the any sports. And few prescriptions like the anisometropia, antimetropia, high cylindrical powers, and prisms, etc. So fitting, we follow few steps. So first step is identification of the patients and patients' needs, requirements, and expectations. So for that, useful tips is just the motivation, highlight the advantages, but mention the limitation as well. Explain the design and method of use. Frame features: optimize front size, good box lens size, face wrap, sufficient pentoscopic tilt, minimal vertex distance, soft nose pads, suitable distance between lenses, adjustable nose pads. Second step is frame selection. So for selecting the frames, A or B side should be optimized and suitable for according to that lenses. Aviator shape, etc., it's not suitable because it's cut the nasal portion of that lens. So here also you can see in diagram the upper portion they given the good because they have the sufficient area to fit, and lower portions not good because in as you see in diagram they are showing how they are not suitable for lens. So depth of that lens as well as upper portion more upper than that, optical center pose should be proper and optimized. So useful tips for that: prefer the metal frame with the adjustable nose pad because sometimes need the adjustment after fitting the lens also slide. So if the patient is frame is metal, then with that nose pad then we can change the angle or angle of that nose pad. By that we can achieve the suitable fit. Both upper and lower suitable portions is very important, and assist the patient or customer to select the suitable frame. If they the customer or patient confuse which one is suitable for that progressive addition lenses. Step 3: frame adjustment. Adjust the frame before taking facial measurement, because when you take once a facial measurement and then again you adjust, then might be the measurement will be changed, and after fitting the lens the patient will not comfortable. Adjust the frame both front and side first. Adjust when delivering the spectacle. Minor adjustment if required. So frame adjustment, back vertex power, it should be always shorter, because if it's shorter, the optics of that lens and area seen by that lenses will wide, and optics will be good, wider field of vision and minimize the aberrations. Next is pentoscopic tilt. It should be 10 to 12 degree, and make sure head is not too high or too low when assessing the tilt. By that we will get the false readings. Next is facial wrap must not be too flat. The lens frame should be not too flat. By that we will not get that any wrap. Then the periphery of that frame, by that we will not get the good field of vision. Next is PD. So for PD, monoocular PD, we will take always monoocular PD, because we know in both eyes both eyes have different PDs. Like the, if we measure the PD like the 62, then one eye might be have 30 and another eye have 32, or one eye have 31 and another one 30.5, or another one have 31.5. So slight change in the PDs. So it's better to take the monoocular PD with the help of that PD scale or by the pupillometer. Pupillometer are more accurate, so it's better to take with pupillometer if available. Monocular PD or frame PD, we have to cross check both are the exact or both are different, making the lens insert and fitting height. Next is fitting height. Fitting height is also sometimes comes little slight different. So take the both as different um, fitting heights. Measure the height for each eye. Do not lower the height measurement, adjust the frame correctly. Next is for taking that height of that, a natural head posture should be and sit at the same level as the patient. Means where you are sitting, the level of eye should be at the same level. Check binocularly from the distance of 1 meter. Use fine marker because if marker is blunt or thick, then might be we will get the and that is spot very large, then it's become confusion. Remove and replace the frame of the patient face and repeat cross check the measurement. So it's better once you check the all measurements of the height and PD, just it's remove and again put that frame on the face of the patient and again cross check that measurements. So by cross checking the everything whatever we are going to get will cross checked and we will get the exact or accurate readings, checking the cut cutout. So by that cutout of that particular that type of the progressive we can check, we will get the area proper area of that near or distance whatever we are going to fit the lenses we can assume before going for the fitting. So here also in first diagram the frame is good and in second if you see the near portion is cutting or getting very less area. So that frame is not suitable. Second frame is not very good for the progressive edition lenses. So for delivery marking distance power we check the marking distance power, addition power, fitting, cross height, and PD. We will cross check after the fitting. So at the time of the delivery, on eye assessment, we have to check everything is normal. The optical center is fitted properly, or major reference point is on the center of that patient or customer. If the everything is suitable good, then we check the distance vision and then near vision. Next is we will give the instruction about that uh, what you have to take care and how you have to see by moving your head as well as your eye. So use the positive languages, remove the marking at the end, maintain a record for the order form. So patient expectation with that progressive lenses as previously discussed, good vision for all distances, quick to get adopted, easy to use, value for money, good technology and trust. So for all these things, it's better to select good progressive lenses. So few things are more important for adjustment for the bifocal and as well as for the progressive edition lenses. So it's better to pre-adjustment, adjust everything frame on the face before taking any measurement, removing temple pressure. Check the pressure on the temples. Sometimes one temple have little more pressure in compared to another. So look at that and adjust before taking and the measurement. Verify vertex distance. Pentoscopic tilt should be 10 to 14 for getting the better optics and good visual area. Alignment of the bridge should be adjusted to fit. Temple length adjustment. Temple equal pressure means the temple have equal pressure, and length always adjustable, because sometimes the length is not suitable for the front is good, very good, but temple is not proper resting on the air. So it's better to check first. If temple length is not proper, then it's better to go for the another frame. So checking the frame fit, good general look, check any misbalance. Both nose pad have similar pressure. Front of both the sides should have the similar fit, means vertex distance have the similar, means it not like some imbalance, misbalance. One vertex distance of one eye is different from the another. Frame fronts should appear at similar height. Spectacle lenses, less weight, durability means good durable, good optics, UV rays protection, SCS resistance, correction for all distances, like in progressive edition lenses are good. Fulfill the need means for that we have to go for the different type of coatings. So sometimes after prescribing the presbyopic lenses, we have some complaints. So see the like this double vision while reading. Objects are tilted. Ground newspaper are slightly tilted. Vertical lines seen to curve inward with a new glasses, but not with old one. So for each problem, uh, again, any measurement whichever we are taken at the time of that frame measurement, or after fitting that lenses, we have done already some mistakes. Cannot walk when wearing new bifocal. The size of the bifocal segment is objectionable. Objects appear too small, too sharp, reflections are annoying. So these complaints we can get from that patients. So we have to cross check if any fitting mistake, any proper any imbalance in the frame, because sometimes we give the good adjustment with good frame alignment, but after few days, due to some pressure or some wrong method of removing that spectacle, the customer came again with uh, along with the complaints. So frame for presbyopes, ensure correct, it should be always correct fit, be comfortable and stable. Place the lenses correctly in front of eyes for the purpose of correction of all distances, aesthetically acceptable. Thank you. Thanks for listening. So this is my mail ID, optom.adit@gmail.com. If you have any query, you can ask now, and later on you can just send the question on my mail ID. I'll try to explain by that. And the references we taken means this information I taken from symptom system of ophthalmic dispensing, Borish, Brook and Borish, and ophthalmic lens and dispensing, Mo Jali. Thank you again.
Okay, thank you, sir. That was a really excellent presentation. Thank you, sir, for one wonderful presentation. And now we will go for question answer session. Now
Okay.
we have wrapped all the question answers. Again, I would like to thank you for the participants for joining with us. Stay safe, stay healthy, and we will be back with the next session. Thank you. Thank you all.